Okay, I'd like to move to hospital consolidation. And I've noticed an increasing pace of announcements of mergers of large systems with each other, often across distinct geographic areas. So the question is, what's motivating these systems to combine, particularly the cross-market mergers? That's what seems to be new. And what do they see as the upside? And is there a rush to do this at a time when the Federal Trade Commission has yet to challenge a cross-market merger?
If I could just
Sure.
start with a couple of observations. Just for the obvious, the cross-market merger obviously does not involve the other issue that policymakers have with hospitals, consolidation within a local market, the potential for higher prices. But needless to say, the hospitals are operating in an environment where many of them are economically challenged by the continuing reduction in utilization of inpatient days. And so any organizations that are operating under duress become more likely to be willing to look at something that would offer at least some cost efficiencies and maybe a better chance at organizational survival. Because on the flip side of this, when you think about these institutions operating in a rural market, and this is true on a different level, some of the maybe single region health plans, while it works, as a not-for-profit institution, if you're on the board, your incentives are probably to continue to let it go. It's a good, have it operate independently, and there may be a lot of justification for that, but also, taking the mindset of someone on the board of one of these institutions, there's nothing that they gain by selling the institution except losing their community influential board seat that they've been on, maybe for some number of years. And my point is, obviously though, when the going gets tough enough, the door opens to consolidation. That hasn't happened on the health plan side, and I'm not going to pick on them, but that's why Blue Cross of Wyoming doesn't seem to be interested in the smallest of the blue plans, by the way, still continues to operate it as an independent entity.
I think but we don't, when you look at the for-profit hospital universe, it's pretty small.
Yes.
So there's a huge not-for-profit thing that we don't analyze that deeply. I kind of look at their financials, at a broader level. But to Matt's point, there's been a lot of headwinds on inpatient volumes. They were masked to some degree by the exchanges and a little bit with Medicaid. So in the first couple of years of the Affordable Care Act, they saw a nice bad debt, pop, and it improved because self-pay patients at least got Medicaid and not exchanges. But then around 2016, you started to see the ACA membership tapering off, and some of the underlying things that were happening around mix shifting to outpatient and ambulatory and all started to play into their P&Ls. And I think what we started to see was, kind of a bifurcation and a divergence of some hospital systems where the managements are just top notch, and I'd say HCA is one of them, who had been investing and doing the right level of capital deployment all along. They weren't lulled into a sense of security by the exchanges. Underlying, they were investing in their ambulatory platform in a big way. And while their stock was pretty depressed, they did buybacks and they introduced a dividend deal most recently, but they kept investing in service lines in their inpatient settings. And so that's why they have a portfolio of hospitals where now they're getting outsized share gains. They're in the market after tax reform especially, because that kind of leveled the playing field in part between the not-for-profits and for-profits to be able to invest more in other health systems, to coming back to Paul's question. So they just, they bought hospital system in Savannah. They've just bought this top hospital system called Mission in Asheville, which gives them a #1 position in this town in North Carolina. They haven't been in that state before. So that's kind of a cross-market story that's happening. Simultaneously, there were some of them who had done these deals, like Tenet, who bought Vanguard, and Community that bought HMA, and they just took on a huge amount of debt to do these deals. And the promise of the ACA did not materialize for them, you know. And this, after the Supreme Court allowed states to walk away from Medicaid expansion, a lot of the earlier promise just never got realized, and that was so painful. And the low volumes, the weaker pricing, it all just crushed them, and their leverage ratios were so high that their bondholders had, you know, they had to do a lot of portfolio rationalization. Community has been selling hospitals because they've had to sell these hospitals, and there are not-for-profit health systems who buy them because, and you know, so do HCA. Why do they buy them? They buy them because they can get better pricing leverage and contract leverage with managed care in certain markets. So it's much more synergistic for someone else than for Community to hold it. That's one. You might go into the same or a new market because you're trying to enter markets where there's population migration. So in the South, Southeast, and Southwest, there's been, you know, better markets because the labor markets are better. So you might enter because of that. And then maybe large systems even do it just for supplies efficiencies, procurement efficiencies. So you have acquirers and those that, you know, who have actually generated enough cash flow to do this, and then those that have to be acquired. And the pipeline is getting richer now again with some of these outpatient pressures on 340B and the like. It's putting, you know, and it's going to continue to put pressure on their P&Ls. You know, all of these things that we're doing with, you know, the drug pricing. There are underlying negative threats for hospitals in that as well, on site of service and you know, clinical visit reimbursement inside a hospital, even an outpatient setting versus outside. ASC rates are getting better per CMS for Medicare. All of this stuff is driving continued consolidation.
Well, and I would just add, you guys can certainly weigh in on this, is when I talk to investors and I give them sort of a Medicare forecast on the reimbursement side for inpatient hospital care, which hasn't looked that bad and doesn't look that bad going forward. They always remind me that people retiring into Medicare, baby boomers retiring into Medicare, is a huge pay cut to the hospitals. So they don't care as much because
negative margin mix shift.
They're taking a big hit from 10,000 baby boomers a day retiring into Medicare, which pays 50% less than commercial payers.
Yeah, that's just enormous in comparison with other, with just the tweaks of the Medicare reimbursement rate from year to year.
Right.
Good. So, so it sounds like it's a story of distress to some extent.
Winners and losers, I guess. The distress and distressed, and ones who are the rescuing them from distress.
Yes, that's right. But you didn't bring up the gaining market power, other than, you know, getting to more of a critical mass in some communities that you may not.
Market power for sure. I mean, that's why Community has been able to get very good multiples. You know, and that's what I've heard too with our separate independent channel checks in many markets from hospitals that want, you know, that extra share catapults you into the number 1 or number 2 position, and now suddenly you get a much better pricing story from the managed care company. You know, HCA bought Houston hospitals from both Tenet and Community because it's really strengthened their position.
So in a sense, this is where it's cross-market. It's really focused on particular markets, leverage in particular markets, as opposed to some of these gigantic mergers, say among Catholic hospital systems.
Or Providence
or
St. Joseph Ascension.
That's right. Where in a sense, you know, presumably these aren't driven by the dynamics in individual markets. It's just acquiring a huge
scale
swath
and
of
scope.
Did you have other than the distress thing that Matt brought up, and you did also, any other sense of, do you think that's valuable as far as leverage being in a lot of markets?
Yeah, I think that not necessarily to a large degree, because the negotiation process is still between the managed care companies and the hospitals still tends to be locally focused. You know, there certainly are some national or regional templates that can potentially get outlined that cross markets for a company that is a parent of hospitals in many different markets. But I haven't, to my understanding, and certainly from back when I was in the industry, I didn't see that translate into real negotiating leverage. Obviously, in-market consolidation is a totally different story.
Yeah. Sure, that's right. Is there a trend in whether plans or providers are gaining leverage? This is a difficult big picture question. But I know that as far as the plans on clearly consolidation is increasing. That's giving providers more leverage. But are the plans feeling more pressure from their clients to be tougher, or in a sense, at this time of booming economy, you wouldn't expect that kind of pressure?
Well, I think the pressure, for example, for the large employer customers is, and I think Anna, you alluded to this earlier, that that there is this trend, and companies that enable this trend of the large companies seeking alternatives to the large managed care. The status quo normal pattern. Okay, we'll choose between Aetna, United, Cigna, and maybe the Blues if that makes sense, and that they're going out to niche companies and maybe a bunch of them and getting a solution that way. And my point, I'm sorry, I should come back to this, is so because you have this, in essence, sort of new source of competition that is putting more pressure on the managed care companies to develop as cost efficient a network as they can put in front of their customers and keep them from going to these alternatives.
Yeah, so some of these alternatives are direct contracting with systems.
Yes.
Yeah. Do you think that's going to become a significant factor in healthcare delivery, or is it going to be just more of a special situations that work because an employer happens to have a lot of people in a market which has the right degree of concentration for it?
Well, I think that there are probably configurations where that can happen, and it hasn't happened yet, and so we probably will see more of it, but it's going to be limited by the number of circumstances where I think you do have to have a concentration of an employer in a certain market and utilizing a provider to a significant degree in that same market. Otherwise, direct contracting is a scale inefficient, very much of a scale inefficient process for a purchaser to engage in. Now, when you start talking about private exchanges and that sort of thing, I won't get into that. But, that's another ballgame potentially.
Okay.
I guess if the question is also around is the question, and I may be misinterpreting it, that as hospitals are consolidating, is that creating pressure on the other side for managed care? That's not part of the question.
Oh yeah, okay, go ahead. Yeah.
If that's part of the question, then managed care has been fortunate to have a whole bunch of secular organic growth tailwinds, right? Also, they're growing huge as Medicare is privatizing to Medicare Advantage, and Medicaid is privatizing. Even though there's no growth in the commercial, self-insured and fully insured membership really on a net basis, they're growing in those. So they are. You have now power concentrated in the hands of 5 large and 3 Medicaid plans in essence, and then the Blues, right? And then they've also regionally seen some consolidation. I mean, Centene bought HealthNet, and bought Fidelis, and WellCare bought Meridian. I mean, these are large regional Medicaid and other plans that are getting absorbed into these large companies. So I feel like while hospitals are consolidating, there's a combination of organic and inorganic scale being built.
And Paul, just I just want to make one point on it because you alluded to it. The Centene acquisition of Fidelis, as a separate point, is significant. Is the largest, to my knowledge, the largest not-for-profit conversion. Effectively, it was handled as bypassing the conversion process, but that's what it was since the IPO of WellChoice Empire Blue Cross in 2002.
Good. Let me go into the spending trend outlook. So the spending trends have been moderate for many years. Certainly a relief, in contrast with earlier trends, but still exceeding wage trends, so that health insurance is becoming less affordable. What's your expectation for the next 5 years as far as aggregate spending trends?
Let me just start with a stab on that just as a backdrop. I've followed a model that was originally developed by Milliman, John Cookson in the 90s that showed the pattern and statistical significance of a relationship between healthcare spending trend and the economic cycle. And basically, the pattern there has been that healthcare spending trend is a lagged cyclical. In other words, demand for healthcare services picks up in an improving economy, but it does so generally 3 to 5 years into a given business cycle, into an economic expansion. And using that model for the current economic expansion, we should have seen that in 2014, with trend bottoming in 2013 and then rising up from there. Now, in fact, the United, just to go back to them, the United Health's figures suggest that the pattern actually was there. It just was so muted in the current environment that where that's been a really strong pressure point on managed care companies in the past, there wasn't even a ripple really this time around. And of course, you also had the obscuring issue of the ACA coming in at the very same time. But let me just offer this one more thing, which is, when you think about trend having gone from basically 0 to the double digits from the mid-1990s to around 2000, 2001, as a generalization, one of the things that was happening there was you had a whole range of new procedures that had not fully penetrated the population, hip replacements, knee replacements, stents. And so going back again to United Health, if you go to their conference calls from 2000, 2001, that's what they kept coming back to, which is those services penetrating a greater and greater segment of the US population. Fast forward to today, and arguably, I'm putting specialty and biotech drugs aside, and that's a big thing, but when you look at the medical side, in terms of new expensive inpatient procedures that are not fully penetrated, the environment's a lot less ripe for an upward turn in healthcare spending trend, or at least that's one perspective on it, and maybe why we didn't see a bigger turn, notwithstanding the historic pattern.
Yeah, that's very interesting, and my sense is that you probably have good visibility in this because it takes quite a while for an important new technology to become widespread enough so that people, at least in theory, should be able to identify, the knee replacements early on before they actually became high volume. And so my sense is that you're not seeing anything in the early phase like knee or hip replacements or some of the other major procedures.
It doesn't seem like we are.
Yeah.
I just feel like, I think there was definitely, as Matt says, in the 90s and even 2000s, a pretty tight linkage between healthcare utilization and the macroeconomic cycle. But that over time, as we've adopted high deductible plans and this may seem like kind of is this true, but I do think there's a structural depression of medical cost trend because of the adoption of very high deductible health plans on the one side, which is a leverage point with the consumer. So they're not just third-party pay, now we're employed, we have insurance, and we're just kind of piling into the healthcare system, no matter whether it's necessary or not. You're actually seeing some consequence from it. And then also mix shifting to ambulatory surgeries and sites of service and all that more recently, which is also reducing the price of services utilized, I think. And then value-based care, so those things are actually all working, I think. And we are in a late macro cycle right now. If that trend had to tick up, it would have ticked up. And I don't see it as a downside risk, for the managed care group anymore. And there was, touch wood, yeah. And there was this long, short thesis always about this macro call, about providers should be bought at the late cycle and plans in the, in the early cycle. And I think we've gone past that. I think, my call is you buy managed care because the fundamentals remain good from an external standpoint. Macroeconomically, policy-wise, they're very adaptable. As long as they don't underprice their business because they're their own worst enemy, we're good, and they can all work. On the provider side, it's the winners and losers. It's survival of the fittest. If you're an HCA, you're gonna, you're good. Frankly, even Tenet and community, they had massive. They've come back from the dead, practically, kind of thing. Community is coming back from the dead, but they're not getting any help from the macroeconomic cycle.
Those are very.
That's right.
Those are very compelling points, particularly on the technology. I guess I would just to play the the other side of it is we're still, whether it's in the employer marketplace or in the Medicare program, is the 20 to 25% of the sickest people end up costing, they account for 80% of the costs. And so that sort of pressure, especially as we get older, remains.
So the demographic trend that that is ongoing and accelerating, even that that may be something that we haven't seen all the fruit bear out. That, of course, what we're tend to be talking about when the companies, for example, will focus on commercial trend
premiums,
per member. That's not to say that what you're talking about isn't a very real dynamic to watch, but
right.
Yeah.
Yeah, one thing I was thinking you might comment on, Paul, see if you think I'm right, is that when it comes to the policy environments, I would say, and this is a big statement, you may say I'm wrong, but that I would say for the last 10 years, the policy environment has not been very aggressive in trying to contain costs.
I agree.
And that could change. I can't predict when, but I'm thinking that with the fiscal situation at the federal government deteriorating so quickly, you could make a prediction that's going to change, and that will affect the aggregate spending trends.
Right. So if you look at the sort of the national healthcare spending statistics, there has been a little bit of an acceleration in sort of a larger sense, and projected spending growth. You're talking 5.5% a year, and they're saying that's largely being driven by Medicare and Medicaid, and the politicians are reluctant to contain costs, and my guess is that they're probably not going to feel a sufficient pressure to do so until
it's really bad.
Until it's really bad.
Until
drug
until the
pricing,
bond market
Right,
tells
until the
them they
next
have
day,
to.
and until the bond market tells them to.
Or maybe because of drugs. I think that's going to be the next burning platform.
Yeah, actually, let's get into the trend we might expect in drugs.
We have, as I was on my soapbox earlier anyway, but just don't think we've even scratched the surface of it. And that could drive double-digit trend for employers if something doesn't give. And that, to me, feels like it's going to end up, if CMS, and I doubt this happens legislatively, but between CMS and the private payers, they can coalesce around an approach, I think, and it's not the middleman. It's because the middleman doesn't, make enough profit to make it even possible for them to make a dent in this. And I kind of look at it as we've seen this movie before. 2009, all the health plans after the whole Obamacare fear, trading at 3 and 5 times. How much profit did they make? Like $5 to $7 billion in total in a $2.5 trillion economy. It was the hospitals that were going to get screwed. And I used to make that call. It's the hospitals. It's going to move down the value chain. No one believed it. Look at where we are 10 years later. Right? The hospitals got screwed. So it's got to be the biopharma at the end is at the heart of it. But of course, we can always say that innovation will stall, and when Secretary Azar comes out with the International Pricing Index, then you say, but we as a nation fund innovation for the rest of the world, but can it continue? And if we have a stable of oncology life-saving therapies, are we going to tell someone that, but the out-of-pocket cost is so much higher that you are a lower-income person, you cannot, you're a working American, you cannot, you cannot afford it? No matter how right-wing you are, that's a hard argument to make.
If I could just, the one thing though I would say is that today, the trend drivers in specialty and related biotech products, it's not big enough to be having a major impact on overall trend.
Not yet.
Not yet, right.
Yeah.
So that's the question, when and to what extent is that going to change as a result of what may be quite good news of a range of new product innovations that apply to broader segments, not just orphan drugs, but broader segments of the population. And that would be an awful lot. It's feasible, but that would be an awful lot to drive overall trend up into something approaching the double digits. And if that did happen, it would, I think, pretty clearly be a real cost crisis, and so you would see any number of possible responses emerge.
Yeah, as far as insurers, the tools that they use to control spending on specialty drugs, which are the tools that have been most effective, and how effective are they in the light of new drugs coming in at extreme prices?
Sovaldi and Harvoni was an example of kind of, the first time I think in 2014 it actually hit the P&Ls of even United Health Group, one drug, who would have thought. And by the end of the year, I think AbbVie came with, what was their drug, I forget now, but anyways, there was a competitive, not a once-a-day therapy and all, but there was something, and they negotiated better prices. Harvoni was the next gen Sovaldi, but there was something else that AbbVie came up with. So competitively, they were able to negotiate better rates with Gilead, actually, on Sovaldi and Harvoni. That was acceptable to everyone. And I think that was actually the time probably where managed care, and Anthem and others were just frustrated with their PBM suppliers. I think Express Scripts and CVS hadn't warned Aetna or Anthem about this new drug coming down the pipe. Like, how hard was that to do? They made more money if that drug was prescribed. So that's the whole misaligned incentive situation. For injectable drugs, it's about, Briova, which is part of United, and then Humana has their own specialty pharmacy and captive PBM. They influence the specialists, and that's the way to incent them differently. But now with the buy and bill thing potentially, getting approved at the CMS level, it gives cover to the private payers, because when CMS does something, I think it's just allows them to adopt that in all settings beyond that payer mix.
I was just going to add to that I don't think that there's really that much that the Uniteds and other carriers can do on the specialty drug side, because they're not going to, in the commercial side, in Medicare, they're generally not going to say no. They're not going to say no. Now, and there isn't necessarily a management technology that that any of them have developed that somehow makes the selection of those who get it and those who don't in some way more efficient. So there isn't that much influence. Now, having said that, when you look at the Medicaid population, that's been state by state determination. It's been, in some states, very restrictive. And there has been, because it's the Medicaid low-income population, politically there's been a willingness in some states to allow that, and it's even more restrictive amongst the inmate
Formulary
populations.
exclusions were done in Medicaid,
Right.
Much less so in commercial. Though you've seen some plans like Harvard Pilgrim and all talk about it even in commercial, but it's one-off and they're very careful.
I see. I was under the impression that in commercial there was a fair amount of restriction of hepatitis C drug use, but you're saying no.
Well, I mean, you have to it has to be documented that it is indeed, that you have hepatitis C.
Yeah.
And I don't know, the doctor prescribes it. Beyond that, I'm not aware of any particular restrictions, although maybe below the radar there is something that I don't know about.
But there is also this thing, and I think in that same rule, CMS has now come up with the approval of biosimilars on 1/1/19, you know, Eylea and all for age-related macular degeneration. I think that's kind of gotten a little. I was talking to somebody who had, you know, about this, but there's a bunch of them, I think. And, you know, that could be not just for Part B drugs, but also for Medicare Advantage. Eylea, Lucentis.
Right.
You know, biosimilar swap-outs for Neulasta, Remicade. That could be huge.
So the administration announced guidance in August that sort of will allow Medicare Advantage plans to use step therapy, and they're allowing the plans to basically combine Part B and Part D. So you could be in a situation where
you have more
Humira
negotiated
could be
pricing.
substituted for Remicade, or the biosimilar version of Remicade, the Pfizer version could be substituted for Remicade.
I'm curious, Paul, what you think, but I think that one area where you might see a successful policy change on drug pricing would be, you know, with regard to what happens today with the patenting and repatenting, and, you know, so you have a drug and it ends up having a 20-year monopoly, effectively, or something like that, as a result of all the, you know, legal maneuvering and the patent laws, beyond what anybody would have envisioned.
Right. So that's a great point. I think that the House Democratic leader has expressed some interest, or I certainly heard this from Democrats, about going back to the idea of being able to break the patent through NIH, through a law called the Bayh-Dole Act, in cases where you can make the argument that, where somebody would be able to make the argument that a drug price is so high that it's creating an access problem. So far, I mean, the NIH has basically been pretty firm, says that's not within the authority of the Bayh-Dole Act, but that issue could come back. And then certainly on the issue of biosimilars, it used to be, it's probably still the case, there's probably a biosimilar seminar a week in Washington, and always you sort of come to the same conclusion that no matter how aggressive the FDA and CMS is in trying to promote the uptake of biosimilars in the marketplace, it's the patent issues that are really, and the legal issues that are keeping biosimilars, are slowing the market penetration in the U.S.
If I could, just one point from the audience I want to catch relevant to what we were talking about earlier.
I'm an attorney and a physician. I just wanted to say that the hepatitis C medication, Sovaldi, Carboni, there are about 10 now, is a special case.
Okay.
Before that, for hepatitis C, the treatments that we had took a year.
Right.
They had all kinds of side effects. They didn't really work. And then suddenly,
right. Okay.
But
not
the new cancer drugs
are a different story. Okay. That's a good point. That's a good point. It is definitely black and white with that particular.
The other issue I would just add on the patents is that this gets into trade policy and the new NAFTA and setting exclusivity for biologics at 10 years versus the current 12 in the U.S. For those who want to bring, if that is finalized, for those who want to bring exclusivity below 12, and there were advocates for this during the original crafting of the law to make it 7, that's an obstacle.
Good. What about labor costs? As the economy is getting very hot, are labor costs and shortages becoming a larger issue for providers these days?
They are generally, and in particular areas, very noticeably for, most noticeably for psychiatric hospitals and outpatient facilities, where there does seem to be more of a shortage on the mental health side. That's become an issue for some of the, that's become an issue for a couple of the public companies, at least, and particularly UHS that we follow.
A little less so for maybe, anesthesia, a little bit in surgical practices as well. but it's not hitting the P&L in such a meaningful way that they're not able to, offset it here and there. Mental health has been a real issue.
Yeah, but what about the large general hospitals?
Somewhat, but not, they seem thus far to be able to, it hasn't been a transformatively higher trend, it's a cost pressure point that they've been able to manage.
And they've been offsetting it with some consolidation. That's like, when you look at their P&Ls, they're generally very simple. It's how much, what's the admissions growth, what's the pricing growth, what's their salaries, wages and benefits, supplies, costs, and other OpEx. Like they have like 5 line items. And they can offset it on SWIB.
Oh, thanks. Now I have a couple of questions on the ACA marketplace exchanges, and you have pointed out in past years that this is not a large part of the publicly traded insurance business, so probably not that big a topic here. But what's your interpretation of the large premium increases for 2018, followed by the much smaller increases for 2019?
Well, I think the interpretation is you've seen this dramatic cycle of profit. First very heavy losses on the initial implementation of the exchange coverage in 2015. That sort of bottomed out. I mean, as one sign of that, the not-for-profit Blue Cross plans that we track in aggregate had their first full year loss since 1988 as a result of the exchanges. That was in 2015. And then with the application of steady rounds of fairly large price increases combined with some changes on the rules, you've almost gone to the other end of the extreme. The margins are, one might say, unreasonably high across the universe of health plans participating in exchange coverage, and somewhat to mitigate that, you've seen those price increases soften very considerably going into 2019. In some cases, they're actually reductions. I will say this, though, the surprise in some ways was when we had 3 consecutive years of very high rate increases that we didn't see what we refer to or they refer to in health insurance or in insurance in general as adverse selection. In other words, that you didn't see the high price increases driving out all the good risks, if you will. Now, one of the reasons for that was that so much of that exchange population is heavily subsidized, and so in fact it's the federal government that's footing the bill much more so than the member. That's probably the biggest reason, but it was still somewhat surprising.
Of course, you did see a fall off in the individual market off the exchanges by a couple million people.
Right.
So that surprises me. It had no impact in terms of the
risk mix. Not substantial, or at least the rate increases kept well ahead of those. Otherwise, we wouldn't be at this point in terms of the profitability.
Yeah. So it sounds like we've over the years talked about the underwriting cycle for commercial insurance in general, and how it's really become more and more muted over time. And but the ACA markets being a brand new, particularly uncertain market, it looks like we just had a huge initial underwriting cycle, which perhaps if things are stable will mute over time, but in a sense a very understandable underwriting cycle because of the great uncertainty about the nature of the customers that would sign up.
Well, it is, in my classic definition for the underwriting cycle, I wouldn't count that, even though on a graph it looks like an underwriting cycle. And the reason I say that is because historically what we've tracked is more the results in the group, core, the largest area of coverage, the group commercial insured market, where we've seen those margins move. And in fact, because of the exchange losses, that has helped to keep the pricing disciplined, if you will, in the group commercial market. And now, as it relates to what happens next, the question is, with many of the not-for-profit plans having made dramatic profit recoveries, and the capital ratio some on the Blue Cross not-for-profit plans, looking like it will recover to the peak level of 5 years ago. Are we going to see more aggressive price competition and maybe even a cycle, or the conditions for a cycle building in 2019?
Oh, that's really interesting.
In 18 it was heavily about the defunding of the cost-sharing subsidies. That's another point. But in 19, you have the repeal of the individual mandate. But again, because it's the carrot and the stick issue, if you're subsidized, it shouldn't, impact the subsidized exchanges. So kind of my forecast would be you'll still see 11 to 12-ish. I'm actually going to go out on a limb and say this. I think it's about 11 to 12 million members subsidized. I think that short-term plans and association health plans are providing some affordability or affordable options for those that are off exchange and don't have the subsidies. And the deregulation could, in fact, at least help pull out, some of the people from either the uninsured or give affordable options to those that are really getting, crushed, I would say, under upper middle class people, under the very partial subsidies or no subsidies, and they're sole proprietors or individuals, and they do not have employer-sponsored insurance. So you might see 1 million or so people coming in on the, on the short-term plans and association health plans, some from uninsured, some from mix shifting, from off exchange. To Paul's earlier point, there was attrition there.
Of course, that might all be affected by the administration's latest proposal to allow states to apply for waivers that might allow the use of the ACA subsidies to buy short-term.
To buy short-term, that helps actually, in some ways. Though, I guess, are you worried that the risk pool under the subsidized plans?
Right, I just wonder whether there are healthy people who say, wow, I can run with this subsidy and
sure. It's potentially deteriorate the risk pool.
But maybe it might help in some other areas.
So if you have full subsidy, you wouldn't. But I think if you have partial subsidy, that's where it becomes an alternative.
Right.
And there are people between 250 and 400% of federal poverty level where the subsidies are just not enough to,
right, they're not.
For them to be able to afford it.
Right.
Yeah. Let me switch to Medicaid expansions. And we saw in the election some significant, movements as far as state referenda, election of Democratic governors. So presumably there's going to be a lot, very significant Medicaid expansion. What's the thinking about the insurers that are in the Medicaid business about their existing and future investments in Medicaid managed care?
I think you're going to see more of it. I think that the precedent from the Medicaid expansion in 2014-15, unlike the exchanges, the Medicaid expansion was quite profitable for the health plans right from the get-go. The Medicaid expansion rates were fairly generous. And so, you had that going on even as the exchanges from a financial standpoint for the health plans were an absolute disaster. Now, this played out a little differently depending on which companies we're talking about, because for the most part, the not-for-profit plans, the regional plans, tended to be a little bit more oriented towards the exchanges. And so they took a big bath. Whereas the public for-profit companies, by business mix, were more oriented towards the Medicaid expansion, the Medicaid business. And so that was a source of profitability for them. But in terms of investment, interest, and focus, it's pretty strong. It's second only to Medicare Advantage.
And there's also a lot of the focus is on Medicaid privatization and not just on Medicaid expansion, which gets a lot of attention in the media, for obvious reasons. But from privatization of state Medicaid to managed Medicaid, the dollars are way higher than the expansion of the market that they see, the plans from Medicaid expansion. And in fact, the age blind and disabled and long-term care populations, they can be $10,000 to $15,000 in premiums a year, and then you have dual eligibles between Medicare and Medicaid that are $25,000 to $30,000. So if you're even making a 2% profit margin on that, it's very big. And earlier to Alvin's question about social determinants of health, the plans are being either encouraged and now increasingly, I think, with the, the Bipartisan Budget Act by 2021, there is upside to being integrated across Medicare and Medicaid for the low-income dual eligibles.
That's right.
So they're investing a lot in Medicaid, even if they were earlier only in Medicare Advantage, because they need to be in Medicaid in states like Florida and Texas to be able to partake of that life across Medicare and Medicaid. So you're seeing interest from companies like Humana that were, at one point, were pretty clear they didn't want to be in Medicaid. They bid heavily in Florida for the reprocurement contract and won very nicely. And now they're waiting for the Texas Star Plus and Star announcements, which are in May and the third quarter of this year. And they're really putting a lot of effort, all of them, into social determinants of health as part of dual special needs plans, and then also separately right now with with the Medicaid ABD and long-term care population.
Good. They're really interesting points. What about probably something you've been looking at for many years is when a state expands its Medicaid program, what's the net impact on hospital bottom lines?
It helps on bad debt. It does. You definitely, it's much better than self-pay. Now, it's not as good as, for sure, from a payer mix perspective, the pricing growth is not as strong as Medicare, and definitely not as good as commercial. But if you have a bed where you're having to treat someone because they come to your emergency room uninsured, this is better. Especially also, over time, if your capacity is underutilized, and outside of HCA in the publicly traded, I don't hear 75% capacity utilization. It was your earlier point around, when prices are okay, you can run at underutilized capacity.
Yeah.
But I think for those of them that are running at underutilized capacity, a Medicaid life is still a life that they're covering some fixed costs around.
I think some of what was driving the Georgia gubernatorial race, which is still, I think, undecided, was the Medicaid issue, but the rural hospitals really pushing, they're pushing for the Medicaid expansion, so they helped the Democratic candidate make an issue out of that.
From the plan standpoint, Paul, you may know this right now. I did a lot of work at one point, and it's kind of, I don't know for a fact, but if the ACA, if a state did not expand Medicaid, and you were at 100, only at 135% of federal poverty level to 400, you got exchanges. Those that fell through the cracks between 100 and 135, I believe, were eligible for exchanges.
Yes. You could be put on the
So
exchanges.
if I'm a Centene or anyone who's in exchanges or Blue Cross of Florida, and I'm managing exchange members who came in from the uninsured in a state like Florida, and Centene and Molina are doing like mid to high single-digit margins. The Molina CEO announced 9 to 10% on the call. So I'm not saying anything that's speculative here. If they expanded Medicaid, and those people moved from an highly profitable exchange program to Medicaid, you actually stand to lose. So I'm not sure, in any case, if Gillum wins, I think it's unclear in any way that the Republican legislature would allow him to expand Medicaid, but I'm not sure the plans want that. Maybe the hospitals would benefit, but.
It seems like more of a hospital.
Well, in a sense, your conclusion about the hospitals show that it sounds like hospitals were treating a fair proportion of the uninsured patients who showed up, because if they weren't,
they had to.
Because they have to stabilize them.
Yeah.
It sounds like maybe they're
and turn them away from ER.
Yeah, they're doing a lot more than stabilizing them. So that's why the Medicaid expansion is such a positive for them, even though the rates are low.
It drops straight to the bottom line for the most part.
Bad debt line item went way down.
Either it's incremental volume, in some cases it is, because there's some new volume that comes out of the expansion, or it's volume that they got paid virtually nothing for, and now they get a low rate. But again, the cost that they're incurring on those persons who are otherwise coming to the hospital is incremental cost is zero. So it all drops to the bottom line.
Good. Thanks. I want to turn to large employer health benefit strategies, and maybe a place to get started is What's your assessment of the potential for the partnership between Amazon, Berkshire Hathaway, and J.P. Morgan, either for the three companies or beyond the three companies?
I think that, we talked a little bit about it. There's angst and dissatisfaction in the very large employers. You're seeing that with Comcast, GE, Apple, Amazon, Walmart. They're doing either direct-to-provider contracting or worksite wellness. They're doing medical, concentric networks and centers of excellence, even offering transportation and all to their workers to go to lower-cost hospitals, even if that means travel and the like. Amazon and Walmart, to me, feel like they have an aspiration to carve a position for themselves in employer-sponsored benefits beyond their own worker population. And so, we talked about Amazon doing drug supply chain, possibly the digital front door in healthcare, and they're doing worksite wellness. I would think, and one knows this for a fact, that they will use the coalition, of which is about 1.2 million members, as a pilot testing ground. You come up with your ideas, and now you have a much larger employee population, and if it works out, then you can market those solutions more broadly. I think Walmart is being underestimated on this as well. They've been looking at their retail stores as a way to, now I think they're going to put not just, they have the drug distribution partnership with Humana, but they're putting retail clinics in their parking lots. And they've been doing a lot for their own workforce, which can be heavily hourly paid and blue collar, on negotiating better rates and contracts and networks for their own workers. And they can, I think they have aspiration. You can listen to, Marcus Osborne is their leader of health transformation, and he speaks in many public events, including at ours. And they definitely seem like they have a broader aspiration to healthcare than their own workforce. And then they are, again, if Amazon is trying to do this online, they are also trying to draw people into their stores on a retail basis, not employers now, but to their stores for low-cost generics for $1 and $9, who then also have them at the same time that you go fill your drug, you go shopping, do some back-to-school shopping for your kid, go get to the clinic in the parking lot and all of that. Well, they could use that as a network for employers as well, and it goes head-to-head against CVS Aetna, and has a more, in a sense, a more aligned value proposition with the front store, because seniors on a fixed income are more likely to shop in Walmart than try to do convenience shopping in CVS for a product that's being sold at 3 times the margin that they could pick it up online or somewhere else. Then they don't have grocery, and the mix and the inventory and the product positioning is not aligned either.
Yeah, one of the things that occurs to me is that when I read about large employers that are very active in innovating in their health benefits, I hear about Walmart. I don't recall ever hearing about J.P. Morgan Chase or Berkshire Hathaway.
Innovative.
So in a sense, I think your notion of being a testing field for Amazon is probably what makes the most sense.
I will just say in a little bit of defense of J.P. Morgan, it was 5-6 years ago they went to a firm-wide high deductible plan offering, which is certainly further than some of the other big banks have gone. They also, with that, they tiered the cost sharing according to income level to some degree. I don't have the exact design, but and that was somewhat innovative in of itself. But since then, it's been a pretty stable configuration.
Yeah.
But back to the plans on this, I think the whole announcement from ABC, this Amazon coalition in January, was a massive wake-up call. And J.P. Morgan had United Health Group and Cigna as their only 2 carriers. So they found, I think both those plans were like, just caught flat-footed with this media announcement one morning. And so I think they're realizing that they cannot, they need to do more on what they call national accounts, which are these very large, self-insured Fortune 100, even Fortune 50 employers. And then Anthem, because Gail Boudreaux is, with the 14-state Anthem, and then you have all of these Blue Cross Blue Shields, and the Henry Ford GM thing that happened on the direct contracting, Blue Cross of Michigan now only has the TPA role to pay claims, a third-party administrator role. And Anthem has a, an opportunity, and I think Gail knows that, and if anyone can do it, she can. Is try to corral the Blue system to develop better value for multi-state employers, because they have 50% market share. They have the most leverage, the Blues, against hospitals and docs, and they do not need to buy anybody because they control half the market in every market. And so I think when I asked both of the CEOs the same question in the third quarter call, and they clearly are on high alert, and United said they're going to pivot to growth in national accounts in 2020. So obviously they're taking steps. And Anthem, Gail said, she's definitely, she gave a long answer about what she plans to do. Kind of to help the Blue system realize its value, because there's more value than they realize, because they're each all an independent little company, 36 of them.
Anna, with just one qualification, as you know, the 50% market share for the Blues wouldn't hold for Medicare Advantage or the Medicare drug plan business.
Commercial.
They were much more, the Blues particularly, I'm really talking the not-for-profit Blues, although to a degree this is true even with Anthem, were much more passive than the public companies when, not surprisingly, the public companies, the for-profit companies, are a lot more aggressive about chasing profit, and that explains in significant degree, scale's a factor too, why the public companies are now close to 2/3 of the market share in Medicare Advantage and taking almost all of the growth.
True, very true.
That's a good point. Got some questions, and I guess that'll be our last segment before we have questions from the audience, about alternative payment approaches. And I want you to characterize how hospitals and physician organizations perceive ACO and bundled payment contracting in Medicare and in private insurance. And, kind of what's the experience of private insurers when they try to do these things?
BPCI, I think or bundled payments even outside, bundled payment initiative. There's a clear aligned incentive for the hospitals, because the decision was made to have the money for the bundle flow through the hospital. So they were able to create narrow network contracts with post-acute and do a lot of post-acute diversion to sometimes even increase length of stay, and then move people to the home and reduce post-acute. The post-acute providers got crushed, except for the survival of the fittest story. So there is a clear kind of incentive alignment there. ACOs, like, what is an ACO? It can be anything. I think it's like, they come up with these announcements about being told these ACOs. Sorry, I don't know what that means.
Yeah, it's a very good point. You get this both with, ACOs, where 900 or however many accountable care organizations. Some of them are really new, innovative, integrated delivery systems in effect, and some of them, have just taken on the organizational title, and there's a lot of busy work going on, but not much real change or innovation, and you can't tell. But you have to get down into the details to tell one from the other, and with somewhat likewise for the value-based reimbursement, in that when you hear plans or policymakers say we're at X percent value-based reimbursement today versus Y percent 3 years ago, that doesn't necessarily really mean as much as what they're saying, because it may just be fee-for-service with a few bells and whistles on top to be able to call it value-based reimbursement. Or on the other end, going from fee-for-service all the way to population-based reimbursement, that's obviously a profound change. But we lack the specificity around these things to come up with good metrics to track them.
When I get asked by investors about this area, really the focus is on most of the questions are on the big dialysis providers, because they're very interested in trying to Medicare is the money loser for them, but that's where most of the patients are. So trying within Medicare to find a way to manage the care of the whole patient. and they don't like the current model very much, and they want, they're looking for legislation to do something different. The large providers are, they may not be, I think the small providers may disagree. But that seems to be sort of in the institutional investor community where most of the focus is when they're asking the, sort of the Washington guy about ACOs.
Yeah, dialysis. I mean, I cover a small dialysis provider. So I watch DaVita and Fresenius just because I cover a little guy.
Right.
My God, that landscape seems so challenged. I mean, are these investors short or long?
I think that I think they either have been long or they'd like to be long, but they're constantly worried about sort of what's going on in California with their...
The Prop 8 thing, at least, that on the SB 1186 is
right,
out
and whether
now,
that's going to come back. And there is a regulation related to third-party payments that we're still awaiting publication on.
I've got
to challenge their model.
Got some questions now, and one is for Matt. And
okay.
I know Matt has to leave early, so let me just ask it.
I have to catch a flight. I apologize.
I
was hoping to avoid any tough questions, but
I have no idea if this is a tough question.
I can't. I got it. Yeah, unfortunately.
But why wouldn't large ERISA self-insuring employers naturally follow Berkshire Hathaway, Amazon, Walmart's lead to gain economies of scale, pool risk, and reduce costs? Is this initiative essentially an AHP? I don't know what AHP means.
Association Health Plan.
Okay.
Right. I think that there's a little bit of maybe a little confusion behind that question, in my view anyway. And this association health plan, first of all, usually applies to small group employers banding together, so where they can't self-insure on their own, that they can as a multi-employer organization and take advantage of the ERISA preemption and so forth. As it relates to the potential scale advantages of Berkshire, Amazon, and JP Morgan, it's not clear that that's what, that they're leveraging, not necessarily scale, because they have scale already, but rather to come together to pool their resources to come up with innovative, innovative models to disrupt and improve the existing sort of vanilla relationships between health plans and large employers.
Okay, thanks, Matt.
Okay, so thank you, everyone.
You missed your plane, so you did a terrific
Turns out Dulles is farther away than I thought.
Great. I've got a question directed to Anna, and it's also about AHPs, Association of Health Plans, but it's really an insurance question. What are some of the obstacles of expanding geographic-based association health plans? How do you expect payers to react to an organization that would both bring in more business but do so by cutting into their margins? Why haven't AHPs taken off, and do you see them as presenting a threat to health benefits exchanges by draining healthy lives away from the exchange, effectively leaving them as high-risk pools?
I guess I'll take the last piece first. I don't see them as draining at least the subsidized exchanges. Because the subsidized exchanges give you full medical coverage, and you're getting the subsidy. So I think that pool is pretty stable. Don't think the risk pool is at risk. It's the off-exchange pool, and there are people that are uninsured that do not have access to employer-sponsored insurance and are not old enough for Medicare or poor enough for Medicaid, that they offer some optionality too. I think the issues have been, and as we were doing a dive into this, clearly this was a very stringently regulated, almost onerously regulated market for all of this while. And the Obama administration certainly made it even more challenging than it had been in the early 2000s. Because there's always been this fear that we will suck out the exchange population out of Obamacare and move it into association health plans. So regulation's been a hurdle. I think state insurance commissioners maybe feel a little bit of a lack of control when you're talking about insurance across state lines, and there's been a lot of work that's being done by this administration to get them comfortable, with this. And I finally saw a piece this week in modern healthcare, showing a comparison of plans with association health plans versus just individual coverage if you didn't have subsidies. And there's a pretty nice difference, and modern healthcare had a nice article saying that. So it seems like they're surmounting the barriers in certain states at the very least, from the bureaucracy potentially at the top. As far as what the plans would do, I think multi-state plans that already have networks and distribution, across the multi-state mode or have distribution at least in more than one state, are going to embrace this. The United Healthcare has been doing National Restaurant Association and other types of association health plans. They're looking at all of this as an opportunity. I think a regional plan, it becomes hard. If Harvard Pilgrim is in Massachusetts, and now you say, oh, you can, kind of market across all of New England, it's not happening easily. They don't have a network to do that.
Yeah. Good. Interesting question about artificial intelligence. To what extent is artificial intelligence a serious market factor in any healthcare sector, biomed, pharma, provider services? IBM's Watson seems to have been greatly oversold as a disruptive innovation for clinical services.
I think, yeah, I'd say AI and machine learning are the buzzword, right now. And the applicability, I'm not an expert in it, but certainly venture capital as well as the various, private providers and tech-enabled services, which I've also started covering now, do make a lot of investments in this. And United Health Group with Optum Ventures is putting money into it. I have one real-life example, a real case example, I should say, of where it's working. It's a company that I cover. There's this notion of payment integrity. I don't know if you guys know what that is. It's basically, the plans are always looking to see where the providers are, overcharging, and they do audits and they do claims checks to see whether there's overpayment, and then it conversely happens on the provider side where they feel getting underpaid. So I cover a name called HMS, Health Management Systems Holdings, and they are a payment integrity provider. They do coordination of benefits in Medicaid. They do payment integrity, and now are increasingly leveraging their data because they have access to all this gigantic claims data because of coordination of benefits into population health management, chronic care management. And they've been investing heavily in AI and machine learning. And it's helping them to drive enormous throughput of claims, which was very hard to do prior to this, and has been really driving up their account sales, their revenue, and their ability to identify more targeted savings, their savings rates, their margins. The last 3-4 quarters, since they've finally had these investments play themselves out. So we call it kind of a big data model where AI and machine learning are helping you with data analytics. So if used properly, I cannot imagine that it wouldn't be useful. Athena Health just got sold to Veritas Capital, a private equity firm, and they also, but another company I covered called Cotiviti in payment integrity, and they're planning to combine some of these platforms. They have the healthcare arm of GE, Veritas, and maybe some of the payer risk solutions that Cotiviti had to kind of stratify providers by their ability to take risk. And you need the ability to have a very strong computational mechanisms. Otherwise, you cannot use the kind of data assets that we have out there. It's got to help. On value-based care, eventually, and beyond administrative, it's going to get into clinical solutions, I think.
Thank you. Could you speak more about trends in mental health care?
Yeah, so from several angles, I guess. I cover UHS, Universal Health Services in Acadia, just as Matt does. And there, the trends there, the broader angle there is demand still exceeds supply, both bed supply and clinical staffing. So there are massive shortages on both ends. The reason being, firstly, we have a shortage and a paucity of mental health providers, especially psychiatrists who want to work in a very challenging inpatient setting. It's extremely hard. Secondly, when they look at CapEx, hospital systems are getting better reimbursement, and reimbursement's hugely challenging for behavioral. In the acute care model versus behavioral, I literally hear things like, unless someone's going to kill themselves or kill someone else, we're not admitting it. Whereas if someone is physically ill, they get admitted. So there's massive reimbursement challenges on who they admit. They want to move them to outpatient if they do offer care, and they put huge length of stay pressure. So day to day to day, you have to justify, inpatient care, which is why maybe people who need care don't get care. So that's kind of the, the provider angle. We downgraded behavioral health as a space last year, and I downgraded Acadia. Kind of have a value call on UHS, but I'm not bullish on behavioral health from an inpatient psych perspective. On the outpatient side, and addiction, eating disorder, substance abuse, there are definitely opportunities. So Acadia is rumored right now, speculated to be on the brink of getting taken out. The question is, will it happen, and will it be the right price and all of that? And I would think the outpatient assets and the addiction assets of Acadia are what's driving interest in private equity. The third angle is I cover Teladoc, which is a telemedicine company. The telemedicine adoption is all happening in mental health. And that's way more right now than even physical treatments, and maybe someday we'll actually get to that promise of longitudinal population health management for seniors first, with home health care and digital health and all that. But right now it's mental health. But mental health supply, even for virtual medicine, is very, very challenged. So they're seeing wage inflation, which is putting pressure on everybody to use it. Those are kind of my, my thoughts, I guess. Magellan is another one I cover, and they have behavioral on the plan side. And UHS and Magellan obviously having a massive battle locally in Florida, where Magellan is refusing to reimburse on their managed Medicaid. So you're seeing this. I cover two companies who are in gridlocked right now with issues.
Thank you. I think we got time for one more question, maybe from the web.
Right. So this is actually a reporter asking, do you see large issuers getting more into the short-term plan landscape, and when?
Very much so, yeah. So much as I think, association health plans have more challenges than short-term health plans, actually. And United has a subsidiary called Golden Rule, and they still operate, right? But those things got pretty challenged with Obamacare. And Cigna had their own, suite of services. Anthem had a product called Tonic at the time. So I think all of them in different ways are going to come back into short-term insurance. In fact, especially because exchanges got challenged, and Aetna, United, and Humana all left the subsidized exchange marketplace because of how much they had to absorb losses and that on their balance sheet at the time. They didn't come back in. So that market now is concentrated among only Centene, Molina, Anthem, and the not-for-profit Blue Cross Blue Shields. So this gives Aetna, Cigna, United, and Anthem, which is very, very small in exchanges, a new opportunity to go after the retail market, because they've been locked out of the retail market at this point.
Thank you. This has been a great conference, and I want to thank the panelists for the phenomenal job they've done. And
Thank you.
And I want to thank the JKTG Foundation for its not only financial support of the conference, but for making the arrangements for the conference, and thank its staff for the great job they've done, and want to thank Alwyn Castle for the important role that she's played in pulling this all together. We stand adjourned.
And I would just ask, if you have a moment, please fill out your evaluations, either leave them on your table or leave them on the table downstairs on your way out the door. Thanks.